Hi, good morning, everyone. Welcome to CS372 again. And this is the final lecture of the quarter. And we are so delighted Dr. Vikas Duvvuri comes back to give us another lecture. And today's topic is uncertain future. And this
Okay, hopefully you can see my slides.
yes.
Let me put it in presentation mode. Is that good?
Yes, great.
Okay. Hi, thank you for having me back. And, this late in the quarter with everything going on. Glad people have joined in. So let's hope we can spend some time on some things that are quite important right now. So my talk will focus on two things. Going back to my slide here. One is COVID-19. We'll talk a little bit about maybe current events that are unfolding that may be worth paying attention to. Many of them uncertain, which will have an impact on how we resume our lives, basically. And then we'll touch on AI with an idea there about some ethical issues that I think you guys left off with in your last lecture. And we'll see maybe if there's some useful framework we can use from the world of psychiatry where ethical issues do come up. These are my disclosures. And you've heard before, I'm medical director of Fremont Hospital, which is a psychiatric hospital, the largest one in the Bay Area. So I'd like to start with this quote. Given the recent events, it's hard to shake them off. We are here for these technical topics, but a lot of things are going around in our world. And I think sometimes it's helpful to maybe try to think that there are things we can do to improve things. So I like this quote by Kennedy. So let's start by looking at where we are today with COVID-19. To some degree, my assumption is that you've been tracking how the illness has progressed in this graph, basically starting here where the yellow begins, beginning of this year. On the x-axis, you have weeks of the year. So 2020 is where the year begins, not a lot of the beginning. And the reason to look at this particular graph, as opposed to the many other graphs you've seen, is that if you look at COVID-19, one of the questions that comes up is, how much is it really changing what's happening in terms of deaths? And this graph, which is basically an influenza-like illness category that the health authorities track year after year, shows you a peak every time it's flu season. So there's about a 10+% peak here in 2018. Again, you get back into winter, a little less, about 8%. Then we're starting to have a bit of a flu peak here, end of 2019. And then we see this giant peak come up in yellow-orange. And what that tells you is that there's this 25% increase over what you'd normally expect. And we already had a bit of that in what we'd expect, about 7 to 8%. So clearly, the impact of COVID-19 is massive compared to certainly the recent years. And this is why, for instance, people are comparing the impact of the deaths from COVID-19 to the flu we had about 100 years ago, the so-called Spanish flu, around 1918. So to begin with, this gives you a sense of the impact and a way to look at it. Another aspect that all of you have probably already seen many different ways is that the impact on people is not uniform. And specifically, if you look at, again, the right side of the graph here, the increase in the percentages, this is hospitalization, but per 100,000 people. So basically, you get the virus, and then what happens? Either nothing happened, you stay home, or you go on with your work or school, or you get hospitalized. And that percentage starts to rise in the 50 to 60 age group. And obviously, the higher, the worse. So you've heard this before, and it remains quite low. One of the things I won't go into later, so I'll just bring it up here and we can talk about questions if that comes up, is that generally speaking, by numbers, the impact has been low in hospitalizations in these lower age groups. But because this illness is influencing, is affecting so many people, it's starting to have a lot of different forms. And one of them is an immune system related effect in children that is being investigated now. So the earlier statement that seemed to be blanket, that, if it's kids, don't worry about it, is not exactly true anymore. The other thing to look at in this virus pandemic is, what is it doing socially? And of course, social issues are a big issue in the world today, and certainly in the US, probably more so. And so what this graph shows you is that the impact in terms of percent of COVID-19 hospitalizations in this particular study they looked at is, you can see, sort of proportional to the impact of the percentage of impact of COVID on the percentage of people of a certain ethnicity. So here it's non-Hispanic whites, here it's Hispanics. But then if you look at the non-Hispanic Black community, this ratio is flipped here. So the impact is getting close to double of the percentage of the population that constitutes this community. So, if you have 18% of these folks in this community, 33% are actually getting hospitalized. So that tells you that there's something odd going on in terms of, from the point a person gets the viral infection to them getting sick and getting symptoms and then getting hospitalized, a number of things have to go wrong for that number to be essentially flipped compared to the other cases. And people are looking at this, and essentially one of the consensus ideas is that, well, it appears as if everything that's wrong with the healthcare system in terms of access and social determinants of health is actually becoming a weakness in the response to COVID-19. And that's a very general statement, of course. But people are starting to realize that, the epidemiologists, starting to realize that literally every factor that impairs access to healthcare, timeliness of response, the ability to actually leave whatever it is you're doing, or maybe the people you have to take care of, or the density of living situations seems to contribute. So one of the topics that this then leads to is, okay, you're getting all these infections. We looked at that big peak early on in terms of illness out there due to the viral infections. How do we start to understand how the virus spreads? So this is a respiratory infection. So you've heard from everyone, make sure you get in the way of a droplet carrying the virus getting to you. Make sure that you wash your hands. So these are the things you're hearing all the time. You're hearing about physical distancing. And the idea is that's to block transmission. So those are general ideas based on prior information we've had from other epidemics involving respiratory infections and involving similar viruses like SARS, like the SARS epidemic before. This is one study that's interesting because in a skilled nursing facility, it was possible to actually track and this is in Washington State, as an infection evolved. Overall, I think it involved less than 100 people. And what what they looked at is basically viral testing by RNA to see if you are positive or not diagnostically. And they did that at 2 points, a week apart, I think. And then they started to track symptoms along the way. And what this particular thing looks at, so on the x-axis, what you find is so-called cycle threshold for N1 target. So N1 is part of the viral structure. And cycle threshold refers to this technique called RT-PCR. It's basically a way to amplify the RNA that makes up the genetic material of the virus. And so the more you need to amplify it, that means the signal is weaker. So as you go on the left side of the graph, you should be seeing good numbers of virus in the samples you're getting. So one of the questions was, well, as we're doing these kinds of assessments on everybody in there, in that facility, is there a difference? Whether when we look at symptoms that they have the classic symptoms of cough, shortness of breath, fever, that they have other symptoms, loss of smell, etc. Or whether they have no symptoms, but then, as in this row, they develop symptoms later, but not at the time of testing. And then finally, are they asymptomatic, meaning that they never develop symptoms? So there is a bit of an outlier here, which could be an interesting question as to why that happened. But the first thing you notice is that red is positive culture, meaning that when somebody tested positive using this PCR method, you then go and see if the sample from that person can grow an infectious virus. Because we've certainly seen that when people have a positive nucleotide test, so positive RNA RT-PCR test, they can just be shedding virus and they are not infectious. So that status exists. So here what they did is they said, okay, now that we know you have a test that came positive on the PCR, let's go look at culture. Are you infectious? And they found that regardless of the symptom presentation, so whether you have these typical symptoms, atypical symptoms, or you're so-called pre-symptomatic, meaning at the time you have no symptoms, you're actually producing the same amount of infectious virus. This is a problem because generally speaking, our strategy in a lot of healthcare settings has been that we're going to get at this problem by looking at symptoms. So we're going to wait for symptoms to develop. And then based on the symptoms developing, we're then going to test. And then we're going to follow the chain of whatever the results show us, as opposed to preemptively testing, either randomly or in a cohort approach, which would pick up these guys, because that's what the study did. They just tested. But if you wait for symptoms, you're going to miss all these pre-symptomatic people, because at the time of the test, everyone that's red here is infectious, but has no symptoms. Then they looked at specifically of the people who are developing these symptoms, and they tell you what they are: fever, cough, shortness of breath, pretty classic initial criteria. They said day 0 is when you actually got those symptoms, and then to the left is so many days before, and then to the right is so many days after your symptoms began. Now let's look at whether we can see a pattern here in terms of how the symptoms, in terms of timing, relate to when the viral shedding is taking place, because that's basically what this positive culture tells you, is that there's infectious virus in the sample. And essentially what you see is up to -6, so 6 days, if you look at this dot here, red dot, up to 6 days before any of these symptoms came up, you have viral shedding that is about halfway in the range of sort of, maximum virus shedding, which is at the top here, to minimum. which you might consider, as a cutoff. So, and again, remember on the left side, the higher you go, basically it's taking you fewer replication cycles to catch the virus in your sample. So that means the viral load is high. You're shedding a lot of virus that's infectious. Because again, and this of course applies to the red. So hopefully that was clear. I know it can be a little tricky. So again, all the dots basically are speaking to a test, which is a PCR test on the market now everywhere, that tells you you've been diagnosed with COVID-19. And then the red is basically telling you, okay, yes, you got the PCR test positive, but in addition, we actually were able to grow infectious virus from the sample we got from you. So that's all of these guys, all the red that you see. So all that red, of course, you would expect in a sick, infectious person to follow after day 0. But what's interesting here is that there's a lot of it before day 0. Again, reinforcing that if you're going to use a strategy where you're only going to select for the people who have symptoms and you're only going to bother with that, then what you have to be ready for is all of these guys being able to infect others, whoever they come in contact with. Certainly people who are at highest risk being then at a risk of developing problems that lead to hospitalization or worse. Another interesting study that was really helpful in starting to understand how the virus affected people and how it could be transmitted was really because of a series of problems in a hospital in South Africa. And this is a very recent study. And basically, they had multiple parts of this hospital, which again, ultimately, the place had to be shut down in some shape or form because of how many infections they had developed from an initial very small number of patients. So as they were going through this terrible problem, one of the things they did, however, was to track carefully where people were, which rooms, which beds, and they also tracked when somebody else got infected that was not sick when they came to the hospital, where was that person physically, geographically, within the hospital, within a certain unit. So it started to help to map out the mechanism of transmission, which is something that is worth keeping your eye on here for this virus, because we're still learning about it. So there's a couple of cases that were positive. You see 4 red beds outlined here. All of these 4 red beds really refer to 2 people. So before they knew, or I guess realized, that they had to do something different about these 2 infectious COVID positive patients, they had them along with others. And so once they realized what was going on, then they moved them, as you see, into beds 25 and 26, which are these 2. So they have rooms by themselves. So that's at this transition point, this transition point. But that apparently, that short exposure being in this bed here and this bed here was enough to start to infect others. And all the greens are the exposed individuals. And it brings up a question when you look at the pattern. So it's one thing to say, okay, so let's look at the droplet mode of transmission. You're coughing out, you're producing droplets, and you don't have a shield or you don't have a way to block that output, then, and the other person doesn't have a way to prevent that from infecting him or her, then you can see how somebody who has their bed right there or to the right here could get impacted, especially if you're stationed right there, you're bedridden, you're not going anywhere. So there's plenty of chance to then spread the virus from you to these other 2. But it starts to then ask the question, how do you do that 1 bed over? And how do you do that 1 bed over diagonally? Similarly, it begs the question, what happened to these two? You know, how do you get somebody infecting someone, A, either from these locations, which are quite far away, and B, when they're contained in these rooms? And so the other mechanism, in this case, this is not a published paper, this is a preprint when this came out. They, of course, talks about droplets for things that are close by. And then they talked about so-called fomite transmission, meaning that surfaces can pick up virus and are being transmitted. So this is basic infection control that hospitals are trained to do in a very extensive way. And certainly many hospitals are, if not all, hospitals are doing this in a more extensive way since the pandemic began. Because one of the guidance provided was that surface transmission is a possibility. So make sure you clean the surfaces around you. And so as a result, one of the things that has happened is that not only do you do the PPE, protective equipment, to prevent transmission from person to person, but you clean surfaces between events or on a schedule. So they think, as in this manuscript, that it could have been through stethoscopes, it could have been through common areas or common modes of transporting equipment that could have led to one person to another. Another issue that this brings up is that in addition to those two possibilities, droplets and so-called fomite, there's a third one, which is airflow. So if the virus is aerosolized, so if it's an aerosol, it can go pretty far, it's light. Then depending on the venting process, the air circulation process within this geographical structure, geographical layout, I guess that's a third possibility that could be carrying the virus. And that's a bit more problematic because our usual ways of infection control will have a hard time catching up with that. You would need to be in isolation rooms. So that's the kind of thing you've heard, for instance, in Wuhan, where they built a special hospital, where every room there was an isolation room, meaning that the airflow is guided in a very specific way so that airflow from one patient doesn't go to another patient. Normally, that's not the case. So you have to build a specific infrastructure to allow that. And allow that at scale if you suspect that that's how this virus is getting around. So this certainly raises that question because you see all these exposed individuals who are quite far apart from any of the red locations. And this happens to be in the medical ICU, but really this phenomenon was seen all across this hospital. It also showed that patient movement was quite frequent in other layouts that they discussed. So again, and ask this question, if this is what's happening, how can you address it structurally? And obviously the extreme and probably most effective way is to have these isolation rooms that were built into the brand new hospital they built in China. But if that's not your go-to plan, then what else can you do? And that's something to think about. So the guidance that's emerging is you got to wear masks. And this is something that was a bit slow in terms of a message to get out, at least here in the US. But this graphic demonstrates this basic idea, which is that, you know, the larger particles, as you can see here, as it gets larger here, bigger droplets, and then the smallest would be going towards aerosol. Aerosol carries further. And essentially, if you have somebody who is infected, who may not look sick at all, doesn't feel sick, so-called asymptomatic, and you are going through normal contact conversations with people, normal speaking releases these particles, and that's what the graphic here shows. And if you're wearing a mask, that's one thing, you know, it will cut down transmission depending on what kind of mask it is. But if you're not, then you have a point of maximal exposure without knowing it. without suspecting it. However, if you are wearing a mask and the person who has the transmission, the source of the transmission, is wearing a mask, then you not only are protecting yourself with a barrier, but most importantly, you're cutting down the emission of these particles when nobody suspects, including you, that you're infectious. So this is the critical basis for why masks are useful as we try to ride out this pandemic. And particularly in the US, where we have now millions of cases and many hundreds of thousands in terms of death. So this is something overall we've come late to. There are still challenges in terms of how effective folks think masks are, or how essential they are. But hopefully this graphic captures this super important point that we have folks who are asymptomatic who are spreading. The prior study hopefully impressed that on you. And the only way to guard that outside of testing every single person all the time is to prevent it or to cut it down. This is an interesting graphic I found from someone I follow on Twitter. And it came out of a local paper from, I believe, Berkeley 100 years ago. So from the flu epidemic in 1918. Wear a mask and save your life. Pretty simple. And as you can see here, it says City of Alameda, County of Alameda, City of Oakland, etc. And has this somewhat humorous line here. You know, wear a mask. Those who do not wear them get sick. The man or woman or child who will not wear a mask now is a dangerous slacker. So clearly they're aggressively pushing this line of thought. So we've talked about how you don't need to have symptoms in order to be somebody who's infectious once you have been infected by the virus. We've talked about how masks can provide source control in the community, cut down the transmission from a spreader who is asymptomatic. The second layer on that that's been coming out and gaining traction because of modeling as well as some data is the idea, and these are 3 studies here, is the idea that there are a small number of people who are actually responsible for most of the spread. So to look at some examples here that was summarized by Eric Topol, 10% of infections in this model were responsible for 80%. Were responsible for 80% of the infections, 10% of the infected individuals. Again, 1 to 5% of the infected individuals were responsible for 80% of the spread. And here 20% were responsible for 80%. So again, kind of getting to that same ballpark, which is the vast majority of people who are transmitting, who are becoming exposed and then becoming infected with the virus are getting infected because of a very small number of people. Now, the implication of this is interesting because unlike a lot of our population and community-based strategies, what super spreading can allow us to do is, as long as you can cut down large events, you basically put an outright ban on large events, it then puts an upper limit on the number of cases that can come out of any single event. So that's the advantage. And you've heard of the choir setting that led to one person who was sick infecting 50 plus individuals within 2.5 hours. So clearly super spreading events can be very effective. And if that is the main source, again, these are individual studies, so the generalizability is the question here. But if it is generalizable, then what this tells us is we don't have to go chase down every single person with contact tracing once we know they're positive and they're infectious. We can actually try to put a cap on the number of people that are in any given physical location at any time for any length of time. And that should immediately start to drop the R0, which is your measure of how many people the virus is spreading to, person to person. So something to keep your eye on as you go forward. Another aspect to keep your eye on, I haven't talked a lot about the DNA testing. Before I go into this slide, I'll just mention that at this point, sorry, I misspoke, RNA testing. So the diagnostic test, as I mentioned before, for COVID-19, they call it the rapid diagnostic test. There's a bunch of different names. They use a nose swab, nasal swab to get the sample. There's recently been a salivary test, so you use saliva. So they're getting better at this. And basically, that looks for RNA from the virus. And then as you saw in the early papers there, in those papers, they actually followed up to say, hey, can you actually grow virus from the test that led to the positive in the RNA PCR test? So those are diagnostics. One of the challenges with those, just to keep an eye out as this evolves, is that there are a lot of differences. Some tests are better than others. Generally, hospital-based tests are very good, but you do have to pay attention to the test type in the consumer market and look at the characteristics. So how many false negatives, how many false positives? And generally speaking, you want as few as possible. So you want the sensitivity and specificity of the test to be close to 100%. And again, I'm talking about the rapid PCR type diagnostic test. One of the aspects of that test to track is that although we may have these tests around, one of the limitations is that how many people can be tested at a time is very different from test to test. So you may have this great test that gives you a result in 5 or 10 minutes, but if you can only test one person at a time, that obviously creates its own issues if you're trying to assess a population. And that in fact is the case with one of the tests. That's very fast. On the other hand, other tests may take a day or so, but can test hundreds of people. So these are some issues to think about. And then sample collection is another thing. Depending on where you are, and I'm not going to show the data for this, depending on where you are in the infection, it may be that when a nasal swab is used to actually sample the inner lining, you might find that the virus isn't there anymore, even though you're positive and you're infectious. So your timeline within the infectious process is another important factor when it comes to diagnostic testing. So a negative test doesn't necessarily mean A, you're negative, and B, that you're that you haven't been infected by the virus. So now let's come to these so-called serology tests. So broadly speaking, these tests are based on antibodies, and this particular feature called an enzyme-linked immunosorbent assay. So these are the tests that have now grown in number. There's a lot of variability in how good they are. What they try to do is they try to detect the antibodies that have been produced in your body after you've been infected. So from looking at the trajectory of individuals, what we find is that it takes roughly about 2 weeks for this to happen after you've been infected. So if you test somebody very early in that process, then you're going to get a negative, even though maybe they'll turn positive later. So for instance, in Korea, therefore, negative tests are doubled. So you have to test negative twice. It's not enough to test negative once. That's because of this timing issue, as I described both with the first test, which is a RNA-based test, and this antibody test. So then the second part, and this is where this could get interesting in terms of a community strategy, is this starts to give you an idea that, hey, you know, such and such a portion of our population, if sampled well, A, has been exposed to the virus, right? Because it's like a historical record. And then B, is potentially immune. What do we know about that? So what you're seeing here in this column here is basically you're detecting the amount of antibody in somebody's blood. So if the titer is 1 to 50, meaning that's a low dilution, right? Compared to say 1 to 40,000 roughly. So if you can take something down to 1 to 40,000, massive dilution, and you're still getting a signal, then that means you have a good amount of antibody because you can dilute it this much. If you're only able to dilute it 1 to 50 to get a signal, that means you don't have very much. And you're starting to get to the point where maybe it's just the limit of the test. So you can do this sort of thing with an ELISA, where you get a sense of how much antibody somebody has. And the idea is that the more antibody you have, the better, because you have a more robust immune response. And these antibodies will potentially protect you the next time you're exposed. A lot of unknowns around this. So A, we don't know for sure that this is the case. There have been some recent very good studies where they've looked at antibodies in much more higher definition. And they've seen that the antibodies generated look promising. They look promising to be able to neutralize the virus. But what we don't know is in an individual who has these antibodies, if they were to be re-exposed, how would that go? So that's the answer we want, but we don't have. The other kind of test you have is so-called lateral flow assay. So basically there is a place to put the sample, and then, you know, that fluid front runs through. Most common type of test you see in this format is a urine pregnancy test. Very similar, right? So you have a control line, you have a test line, and then basically you see if you get, the control has to be positive, meaning test works, and then the test either is positive or negative. And these are obviously much more widely circulatable. This needs a particular lab setting to run on the left side, but can be scaled quite effectively. So once these are reliable and people benchmark them well, then it can become a pretty important resource in the community as time goes on for us to characterize, you know, who in our community is potentially immune. And then that leads us to the next question, which is, well, how long is immunity for? Say you're immune, now what? Do you need a booster? How does that work? Especially in this period where we don't have either super effective treatments or we don't have a vaccine. So again, definitely important to keep your eye on antibody-based tests, what their characteristics are. One of the things you want to make sure is they don't have a lot of false positives, because that can be a big issue. The other thing to look at is the population you're in, and I'm not discussing this in much detail other than to mention it, which is it matters how many people in our community has been exposed to the virus to actually use this test. Because if the prevalence in your community is super low, then you're going to bump up against the false positive rate of the test. And essentially, you're not going to be able to tell whether the number you're getting from testing is just the test characteristic, or is this actually because you've been positive? If on the other hand, you know, 5% of the community or 10% has been exposed to the virus and has antibodies, then the good tests are certainly far below that in terms of false positives. So you can be sure that a good number of those cases are actually real positives. So one of the thoughts about using this sort of test has been potentially to roll it out among healthcare workers, because they are readily exposed because of what they do. And so, and it also is very helpful even within facilities or organizations to know if you have a large pool of healthcare workers who are positive for these antibodies and healthy otherwise, because then potentially you have a pool that can protect your workforce and the environment they work in, and obviously for themselves as well, which is true really for all individuals. So kind of following that train of thought, Antibodies are a critical thing to watch. Before we're getting to the point where a vaccine is available, one of the things people are looking for is, can we use plasma, which is a portion of people's blood, to actually help other individuals who've become sick from the virus. So you could have people in an ICU who've been super sick, now getting better. And one of the goals is that potentially you can take the plasma from people who have recovered from COVID-19, where you can verify they have antibodies, and then use those antibodies to actually treat a different person. There are some technicalities here in that what you're doing, this intervention, doesn't itself cause damage. And there are ways to mitigate that risk and certainly to track it. There's been some previous data that shows that there are successes with other viruses. So there is hope that this will also play out with COVID-19. And so there are some very small studies that indicated that, for instance, 10 out of 10 patients didn't die when they got plasma versus smaller number that had the same positive result and they didn't get it. But these are really not statistically informative trials. So we're really waiting for good data on this to actually inform us as to whether it's effective. The other aspect here you realize is that somebody has to donate blood for this to work. So the sourcing of this material becomes an issue because it's not infinite. Although it could be once the curve flips so that the people exposed are larger than the people who are getting sick, or at least on the same playing field. So, of course, everybody wants to know when we're going to get a vaccine. And for all the reasons you've seen with testing, right, which has taken quite a while, certainly in the US to be available. The NIH, and Francis Collins in this article is the director of the NIH. The NIH leaders and Component Institute leaders have basically proposed that there ought to be this organized public-private approach to not just developing vaccines, which is being done by everyone, lots of companies out there, but to coordinate the process of testing in parallel. So that's their proposal, is that there needs to be this parallel approach. There's a central way to clear the data. There's a central way to look at safety. There's a central way to license it. So each of these words really here, having a platform, having licensure and distribution. So you want to know that the vaccine's safe. You want to be confident that that's the case, unlike what we've seen with testing, where there are some tests that are really not that good. And you want it to be available, which means distribution becomes an issue. So who's going to get it first? How are they going to get it? What is the mechanism of distribution? And these become really important issues once we know an effective vaccine is available. And will that be either hoarded or blocked depending on the region or the country? So these are issues that really are far from being settled at this point and will become super important when it is clear we have a vaccine that is effective. The other thought process here is the speed to getting a vaccine. And many of the voices that have worked in the field of creating vaccines have cautioned against speed being the main criterion, because unlike potentially medications which are given to a subset of the population, ideally a vaccine is really given to everyone who's susceptible. So that is tens, if not hundreds of millions of people. And so a 1 in a million reaction in 100 million is 100 people. And if that's a lethal reaction, you're going to have a problem. So safety becomes a massive issue when it comes to vaccine development, because not only are you doing it at such a massive scale, you're doing it on people who are presumably otherwise healthy, and you're doing it year after year. So whatever that risk is going to be amplified if you are not careful in setting the standards. So making sure the standards are uniform. This was Time to do a little time check. So Edward, where are we in timing? Oh, I can't hear you, sorry.
Sorry, we have 30 more minutes.
30 minutes, okay, perfect. So 2 sections here. This is going to be, as the topic says, coping with COVID, and then we'll get to AI after this. So one of the things that we're seeing is there's been, one of the folks at Google brought up that something like a third of the searches that they're seeing of late have something to do with anxiety. This is, I haven't seen data on every aspect of mental health related problems, but one of the observations is that there has been a bit of a boomerang. In the early phase of the illness, there was a dip in terms of folks coming into hospitals for mental health reasons. Clinics, of course, started to be shut down or go virtual because of infection risk. But there was really a withdrawal of sorts. And then in the last month or so, that has flipped, where there are more numbers coming in, they're needing help. Many of the sources where folks would normally get help are closed. Again, because they have their own problems in terms of managing infection, or maybe the folks working there don't want to be exposed, or maybe it's a collective decision and they decide it's not worth taking that risk at their level of care, or they're not able to protect themselves adequately. So put together, this puts a strain on the resources out there for mental health, where on the one side you have an increased incidence of people wanting help, and on the other side you have a deficit in resources that have been out there typically to help people in the outpatient setting, for sure. So one of the big growth items has been virtual care. Just like we're doing the Zoom meeting, a lot of providers out there have a variety of platforms that they've literally jumped to overnight. And in case you haven't seen this, you definitely should go and check it out. Certainly on the internet, you'll find that there's been an explosion of providers out there who are providing services virtually. Therapists, psychiatrists, the whole deal. And one way is the professional organizations, and if that's helpful, I can send some of those links later, where you can go to their sites, and they've been organizing ways of people to seek help. Many of the telehealth companies that existed before have really exploded. One of the aspects of how this has played out is that CMS, which is what controls Medicare for the US federal government, has loosened restrictions on how you can deliver care. There were a lot of technical limitations on how you could use video, and what privacy issues there were, and what state-to-state issues there were, and a whole host of, and payment issues, whole host of barriers to using telehealth. Whereas the vast majority of those have been removed, although on an emergency basis, meaning that as long as the emergency is in effect, those rules are suspended. But unless a fix is created, we will go back to those rules. And so the hope is that CMS will act on those to somehow make a permanent version, so that this experiment with virtual care that has really exploded will continue where it's appropriate. Now, in terms of a campus setting on a personal level, there have been other issues. Some places have not allowed students to live in their dorms. So all of a sudden, these folks have had to find ways to live someplace. Other places allow you to live there, but it's very isolating. Because again, social support, it's been shown again and again, is a major ingredient in how people get through crises in life in general, not just for this pandemic. And so one of the ways COVID-19 has really impacted both life and death is that isolation has made both processes more miserable. And So one of the things that people have been doing and continue to urge folks to do, certainly, every provider should be urging their patients to do, is even though physically you may be limited in how much contact you have, make sure you reach out to people, because now, again, video resources are everywhere. So make it almost a habit, make it a part of your routine, because normally maybe you walk or go somewhere or you show up to work and there is that very casual interaction that keeps things going on a social level. That's gone. So now you have to schedule that into whatever you do. And certainly I'm hearing many companies are actually doing this as a prelude to their normally scheduled meetings through Zoom. In terms of coping, the other aspect here is uncertainty. COVID-19 is a bit like Russian roulette. You don't know who's going to get hit. You don't know whether somebody gets sick or not. Largely speaking, it affects people who are older, as we saw earlier. It affects people with certain pre-existing conditions. And then it starts to get murky, because there are a lot of people, either 30 or 40-year-olds and 50-year-olds who didn't have any conditions that should have been a problem and didn't think they were going to be affected, and they got affected, and pretty severely. So that raises this fear factor in individuals, because you're basically toying with this low risk. So say on balance, maybe it's 1% of the people who have symptoms, so-called case fatality rate, that are going to die from the illness. And we know predominantly that's a certain subset. But there's a tail to it. There's maybe 5% who end up in the hospital. Half of that ends up in the ICU. And nobody wants to be that person. Nobody wants to be the person who ends up in an ICU or ends up in a hospital, even though they recover. Because the illness, as we learn more about it, and as it spreads to millions of people, seems to affect all parts of your body. Recent data shows it affects your immune system in a variety of ways. Clotting disorders are coming up in people who are otherwise, they have no reason to have clotting disorders, as far as we know. So it's really leading to a lot of thinking and head scratching in the medical community as they begin to learn what are all the forms of this illness. Looking back, if you look at what people saw with the flu epidemic in 1918, it was this range of symptoms that was really quite startling. If you go back to those videos or those descriptions, you find people who have so-called hemorrhagic type fever in pretty profuse amounts, where they just start bleeding out in the middle of what is otherwise this straightforward infection that you think you understand. In that case, a lot of younger people got affected too. So we have it a little bit better in the sense that the impact is to a smaller subset, and not everyone. But at the same token, there is still an element of randomness to who it affects. So this uncertainty and what it does to you and where it's coming from, because you cannot actually see it coming, because we talked about asymptomatic transmission earlier. So you don't necessarily associate COVID-19 with only getting sick from somebody else who's sick. So if you start off with worrying about things, this certainly doesn't help, because it gives you, in a way, a reason to. Now, routines are really helpful is the general recommendation that a lot of us are giving folks, because it is true, there are a lot of things in the world you cannot control, but there are definitely some things you can. And when you start with kind of cleaning up your day-to-day life such that you exert a little more control on the things you can, your routines, things that you want to be mindful of because you want them to be effective and useful, then it generally is the case that people feel like there is more they can do to impact how they live. And then, of course, some of it is sort of the technical aspects of how you make sure that you're limiting contact with people, broadly speaking, you're protecting yourself. So this is where the use of masks, this is where, you know, you maintain a clean area versus a dirty area in terms of your belongings. If you're somebody that has to go out, has to interact with people like healthcare workers. And they have gotten used to this. And one of the reassuring things is that in the middle of this pandemic, so one of the things you'd expect is, you know, if this was really difficult to control as an infection, and it was a real problem if people are together, and no matter what they did, they'd get sick and infected, you would find these big outbreaks all over every healthcare facility. And as it turns out, that's not the case. Some of the studies early on that were done to look at, hey, how are people getting infected among healthcare workers once they have adequate PPE and once they're doing what they should be doing? Turns out it's more linked to the zip code they live in than the floor of the hospital or the unit of the hospital they work in. So largely, at least from what we can see, hospitals are used to managing infections. And certainly all, if not many, have ramped up their efforts in this direction because the guidance has been clear. And they've been able to contain the impact of people coming in with the virus. So it's not simply, you know, you're going to the supermarket where you don't know what's happening. This is people intentionally coming there because that's why they should be there. They should be there because they're sick and they have COVID-19. And so even with that happening, you don't hear of these outbreaks. So that's reassuring because what it says is that if you do the things that we know work, it seems like we're able to manage the situation. So that should, I think, give individuals in the community some comfort that as long as you kind of follow that process, it is actually quite manageable. But again, the burden is not to be minimized mentally because the major hit of COVID-19 from a human perspective is social isolation. If you're not careful about being intentional in maintaining some level of social interaction remotely. And probably increasingly as society opens up, maybe even physically with adequate physical distancing. So those are some thoughts on this. And of course, if you have other questions, we can go back to this. So do we have about 20 minutes or how are we on time?
We have about 15 minutes.
15 minutes, perfect.
Yeah, you go over slightly, it's okay.
Okay.
Yes.
We should be good. So wanted to leave with this topic that you guys had discussed last time in terms of, in a way, the frontier in AI. The simple starting point that Edward brought up is, you know, in human society, when a person either makes a mistake or commits a crime, there's sort of a process associated with it. There's a legal system to handle it. There's a way to understand it and then take it through its conclusion. If instead of human actors, we have machines and really algorithms that are the actors, how do we think about this? There's definitely several things being written about this, and this is one article within a publication that's on technology and the law from Harvard. And they talk about using transparency and accountability in a specific way. So let's start with what is an error. So once you say you want to hold an algorithm or a product or a machine accountable, a computer accountable, then you have to define what you're holding it accountable for. So what's the error? And ultimately, maybe a broad definition would be that it would be like any other product. You know, we have in healthcare, we have medical devices. In other, you know, you have cars, you have other mechanical objects that perform tasks, and you look at it and you say, okay, is this supposed to be doing this? And if it is, great. If it's not, well, then you promised this, but you gave me that, you're liable. So a defective product. So maybe software and hardware as well can be looked at from a purely delivery standpoint. Are you delivering the product you promised? Then there's a question of who's responsible. Is it the person operating it? Is it the person who built it? So, you know, in terms of things we understand, car manufacturers versus the person who drives it. And that can be, of course, different when you talk about software and hardware, because both the creator and operator might be linked, or both might be external to the individual who's actually harmed. So this concept of transparency and accountability comes at from the perspective, again, very simplistic from my perspective, of saying, you know, and they give this example of a mousetrap. You build a better mousetrap. Okay. So if you build a better mousetrap and you're going to promise that it's going to do these things that are better, well, you should be able to spell out exactly how it does it. And the idea is that in hardware and software, you should be able to do this. But it seems like, and this is what they argue here, that's hard to do. Because as you start to have interactions between software and the outside world, it is harder and harder to define what is expected. And it's harder and harder to define exactly what this software or hardware does. And there you have a problem, because now, what is the product? Is the product the thing you launched on day one, which is some beta version? Or is the product the next version where you say, okay, finally, now we've gotten it right. So this is really what we mean when we say we're going to do something good for you. And then accountability stems from that, in the sense that either a third party or the creator itself takes certain steps to say, hey, we're doing what we told you we're doing. Well, how do you do that if it's an interactional process as opposed to A leads to B leads to C? So one of the ways that they look at this is something that you guys know a lot more than I do, which is this thing called the halting problem. And basically, this is something that Turing provided a proof for. In my simplistic thinking, it basically says that in all the algorithms out there and in all the ways it can crash, you cannot create a process, a supervisory process, let's say, that will point out and prevent all those crashes. So, and there's different ways of actually formulating this halting problem. But generally speaking, Turing proved that from a computer science perspective, you cannot have this perfect supervisory algorithm. So if you start at the root of this whole issue and say, hey, can I deliver on the promise? The halting problem actually says, maybe you can or not, but there's sure no computer science process that can guarantee it, because fundamentally you cannot actually create such a process, even though your product might be great and might never lead to any problems. So then what is plan B? Do you just say, you know what, yeah, Turing proved this thing, good luck? So what they suggest is specifications. So yes, you can trust in the implementation, but you have to verify. And maybe you start to have specifications of what this product is supposed to do that are these endpoints. And the argument from their end is that then you can engineer your solution such that not only does it meet those points, you can develop processes that are like a supervisory algorithm that specifically checks that, and that's doable. Certainly you can construct it so that it's doable. So the idea then is, instead of having this general idea that there's transparency as in I know exactly what happens here, we actually have technical transparency, which is there are specific things we build and we say, hey, these are the things we want whenever there's AI. It needs to be able to do 1, 2, 3. And then to make sure there's accountability, we actually put that in effect and I'll talk about this a little more, in a proactive way. So as you can do that, as people have access to it openly, when there's a problem, you see it right away. It's sort of like, I guess, again, from my simple-minded approach, error checking. But knowing full well at the beginning that you're not going to cover all the space that's there. You're only going to pick certain things that matter to you the most. And then that needs to become the next frontier. What are those things that matter to you the most? Will that be something universal? Or will that be a mix of something universal along with things that are specific to the application? So if you have an AI-driven car, hopefully that means there's some way to make sure it will do well under simulated conditions or real conditions where you're putting obstacles and keep the driver safe. But knowing that it cannot be tested under all conditions if that is truly an AI-driven process. So something to think about. Now, a different way to look at this, so that's one thought process. Different way to look at this is, what do we do with people? So generally speaking, laws apply to people. If you do something that you're liable for, then you have to kind of deal with the legal consequences. There is one exception, and that exception in psychiatry is called the insanity defense. And basically, conceptually, what that says is that if, as an individual, a case can be made that due to a severe mental illness, your brain is not working the way it should, and it gets in the way of you recognizing the wrongfulness of your action, then you're not responsible. So this is current law. It's kind of changed over the years in the US, and that's its current form. So it's possible that you could have some kind of a corollary where you look for severe disruption of algorithmic function. And if there's this severe disruption, then you say, okay, all I did was I used this process. I am an operator. And if there was a severe disruption, what that means is it's not my responsibility. The disruption is from the algorithm, which means it's the creator's problem, so to speak. In humans, the creator, is depending on your disposition, either God or nature or some combination thereof. So we don't have a process for that. But with AI, you have to go there, and you have to define who is ultimately the creator of the software, especially if it's maybe multiple people or multiple entities. So if we take this logic, then again, in order to say there was a severe disruption, you need these proxy points for normal operation. You need specifications. And that can, again, guide you. So it kind of ties in with the first point. And then the idea is that in such a system, you begin with an expectation of accountability and transparency, meaning that the person who's creating this framework actually says, hey, look, these things can happen, so we're going to do X, Y, Z. And we're going to keep feeding you these metrics of X, Y, Z. And obviously, if something's wrong there, we're going to jump on it, and our product is engineered to do that. But everything else is going to be a learning process. And of course, maybe there is some expectation that once there is a problem, you will now create a new metric to actually incorporate this new problem. So it has to be an iterative process. It cannot be static, is at least what I would propose. So that's the legal side. Ethically, as I said, you have to pre-assess. Ideally, you want to pre-specify these operational benchmarks, share these benchmarks, maybe have an industry standard, maybe multiple industry standards, some that are universal, some may be specific to your product or product line. And it leads to some other things, as AI needs a lot of data, it kind of raises the question, well, are people consenting to having human data be part of these training sets? As we get into these ethical questions. Maybe there can be liability protection when you have an open process of improvement. So anybody who signs on to this process where they share data, they share benchmarks, they're proactive, that is their insurance in a way to be protected from liability, because they are being forthright and saying, hey, I'm participating in this framework. And again, I've certainly not seen this, and I, to my review at least, there isn't legislation out there that helps with this. But this ought to be something you want to think along the lines of. And then finally, active versus post hoc, meaning, healthcare certainly has this where there may be algorithms you apply to do certain things, maybe look at an image and say, hey, is this category A or B in terms of illness, which will then have a consequence in terms of maybe how severe it is or what treatment to use. So if done wrong, it'll cause harm. Currently, that's always backstopped by physicians who are signing off. So that would be an active human oversight component. Is that always necessary? It may be possible that in certain situations, you just have to have an active human oversight component. And as I understand it, that's the case for driving with these intelligent systems that maybe have the capacity to do what they need to do, but there's essentially, for the sake of accountability, there's a final human component that says, ultimately it's my decision. But does that need to be the case? I'm not sure. It probably depends on how good AI gets to some degree, but also how, I think more so, how good the social and legislative process gets in framing. How do you actually build trust in these systems such that when there are mistakes, it doesn't lead to the collapse of the whole thing? And instead, there's some kind of an iterative process that people walk into knowing the risk of. So that's all I have. Thank you again. I can't hear you.
Thank you so much. Yeah, thank you so much, Dr. Duvvuri. Please ask your questions or post your questions on the chat room. At the same time, I'm going to play a video which happened just yesterday in Taiwan. So yeah, feel free to just post your question at the same time when I'm playing the video. This is an accident of Tesla. So you look at it. Oh, I haven't shared the screen yet.
Should I do I need to do something on my end?
Not really.
Okay.
So the question is, why Tesla get into this problem? So a Tesla driving on the highway, and there's a truck laying in the middle of the highway. The Tesla just runs into it.
Oh my God.
Right, and you don't see the deceleration of this vehicle, and maybe Tesla hasn't seen this kind of scene before, right? The white top of a truck laying in front of the path. So who is liable? The driver, right? Maybe the driver is watching his mobile phone.
Yeah.
Or it's Tesla's fault. And even Tesla with the 1 million vehicles collecting adult data, and this is probably a surprise to Tesla. Okay, with that, I think still open the floor to the students.
Yeah, actually, I have a question concerning the application of AI in medicine. So, for example, if we train an AI diagnosis system, for example, to specify the breast cancer, and if it failed in some cases and caused some people who actually have the breast cancer, but the diagnosis result is negative, then in these cases, who should be responsible for the failure of the diagnosis system?
Yeah, I mean, that falls, it's in the same, in my mind, it's in the same category of questions with that Tesla crash, as well as, my last few slides. I think it comes down to at a minimal level, and this is, I'm looking at it more, I guess, procedurally or ethically rather than legally, because the legal aspect will, you know, ultimately you want to go find a lawyer who can tell you, or a legal expert who can tell you this based on the country's laws or that region's laws. But procedurally or ethically, it seems like the idea is when somebody got this diagnosis, you know, through this algorithm, there hopefully was a consenting process. And it was a transparent process where they were told, you know what, you're gonna get this mammogram, you're gonna get whatever CT scan, and then we're gonna run it through this algorithm and we're gonna give you the output of the algorithm. If you do that, if the patient agrees, and then you can educate them, and you know what, yeah, it can get it right, it can get it wrong. And then the patient may say, you know what, this is great, you have all this high tech, but I still want a radiologist and an oncologist to look at it. And as it turns out, at least in medicine for breast cancer, the one you brought up, there's actually specifically trained radiologists. There are people who look at nothing other than breast cancer. And most places, as far as I know, you actually have to have them look at those scans in order to say yes or no, because it can be tricky. That doesn't mean that a machine cannot do a better job, but you know, where that question goes is, what was that conversation initially? And if the conversation was transparent and the patient said, you know what, it's fine, I don't want to wait for this specialist, radiologist, whoever to look at this because maybe it takes longer or some other reason, or maybe they're not available. It's fine, I'll do what the machine said because maybe you gave me this data that said this machine does a great job, right? You've given me the pitch that shows prior results and I consent to it. So then, you know, right or wrong, at least there is some common understanding to begin with, and there's transparency. But then it's also important in those cases to, ahead of time, talk about what happens when you're wrong for that exact reason. Because, you know, as I pointed out, and as we know lots of cases, this is a process that learns continuously, which means it's gonna make mistakes on that way. So what do you do with that? And what is the person who's buying into this comfortable with? So, you know, to kind of go back to my slides, maybe one of the upshots of that process ought to be for the future that there has to be a requirement that you have to discuss outliers, you have to discuss specifically adverse events in your consenting process. Just like now when people sell you a medication, same thing is done. The pharmaceutical company comes out with this long list of things, which unfortunately is on the border of being useless because it has 1,000 things on there that if you read everything, you basically think you're going to die even if you take a pill of, you know, aspirin or Tylenol, which is over the counter. So of course they've gone the other way, but bottom line, at least you cannot say, oh, that information was not available. So that's a starting point. It may not be the most useful, but it pushes for transparency. And it pushes people to think about how they weigh the decision. So I don't know if that answers your question, but my answer is more along the lines of the thought process rather than wrong or right.
I see. I mean, that is very inspiring. Thank you.
Sure. Thanks for the question.